Advisory Committee for Clinical Trials. Thanks for this opportunity. So this is the list of my disclosures, and now let's move to the presentation. The goal of this presentation is actually showing you the practicalities and possibly the flexibility of the new MS criteria. To do so, I'll be using a selection of cases from our MS clinic in Naples, Italy, that I have been collecting from the meeting that we had in Barcelona, organized by Prof. Montalban, until basically last month. And as you will see, the initial classification of these individuals is based on the modality of presentation and on the number of MS typical regions affected on the first MRI. Please notice that all the MRIs were acquired in clinical practice in research settings, so if they look nice, it's mostly thanks to Giuseppe Pontillo. Thank you. So, in our experience, in most cases presenting with suspected MS, so about 60% of patients, we found on the first assessment 2 or 3 regions affected on MRI. So it's 2 or 3 regions out of 5, juxtacortical, periventricular, infratentorial, spinal cord, and/or optic nerve. So in this situation, we can have 2 different modalities of presentation. It's either the presence of signs or symptoms suggestive of MS or incidental findings. And of course, we need to rule out any other possible diagnosis. Once we know that we have at least 2 topographies involved, we can get to the diagnosis in different multiple ways. So this is a case of a 34-year-old man with the cerebellar syndrome at onset, and on the first MRI we had lesions in juxtacortical, periventricular, and infratentorial regions. So 3 regions were affected on the first MRI, and we had symptoms suggestive of MS. So in this specific case, we have at least 2 regions affected, and we can get to the diagnosis with the CSF, and this is exactly the same as with the previous set of criteria, or with the central vein sign using the SELECT6. Another possibility is dissemination in time, so new relapses on follow-up, new T2 lesion on follow-up MRI, or the concomitant presence of gut-enhancing and not gut-enhancing lesion. The other possibility would be demonstrating the involvement of 4 or 5 regions. So if we think of the past set of criteria, what we would have done possibly in this case is having the CSF for the oligoclonal bands, or some more MRIs or follow-up to get the diagnosis of MS. Actually, this gentleman came to clinic with already acquired SWI images, and we were able to demonstrate the SELECT6 rule. So we actually had the diagnosis already using the first MRI scan by integrating conventional FLAIR images to SWI sequences. Alternatively, the new set of criteria would have allowed the use of spinal cord and optic nerve imaging to get to 4 regions, and so automatic diagnosis of MS. Here we have a totally different case. This is an 18-year-old lady who was advised actually to have brain MRI after a car accident, even though she had no actual brain head trauma. Clinical history was negative for any neurological events, and examination was normal, but brain MRI found some periventricular and some juxtacortical lesions. So here we are in a different part of the flow chart. Here we have incidental MRI findings, and we were able to demonstrate the involvement of 2 brain regions. In this case, we can use CSF, central vein sign, or dissemination in time. So, using the previous set of criteria, this lady would not have qualified to have MS. She was RIS. But actually, after 6 months, she had 3 new T2 lesions and 1 clinical relapse. So we demonstrated the IT, but actually, this lady already had MS. It was just a matter of classification. With the new set of criteria, this lady would have been MS already at the time of the first MRI findings suggestive of MS. And this is quite interesting case because we had a positive kappa index, but negative oligoclonal bands, because the IgGs were very low in the CSF, and this can happen because immune cells produce more K kappa-free light chain than IgG, so you can get positive kappa index and negative oligoclonal bands. Especially, this has been described especially in young patients as this is the case. In quite a number of cases, we were able to demonstrate the involvement of 4 or 5 regions, so to get immediate diagnosis of MS. Again, here we need signs or symptoms suggestive of MS. We need to rule out any other possible diagnosis, and once we demonstrate 4 or 5 brain regions, we can do the diagnosis of MS. This is a 62-year-old man, absolutely healthy, except for a number of cardiovascular risk factors, including smoking, high cholesterol, and high blood pressure. And he presented with sensory motor symptoms in the legs that were also confirmed by neurological examination. Brain MRI showed lesions in the periventricular area and juxtacortical area, but also some white matter changes that, to be honest, looked more age-related than MS-related. Interestingly enough, we were able to acquire OCT and visual evoked potentials that were positive for demyelinating pathology to the right. So we already have 3 regions in this gentleman, and a huge possibility of demonstrating the diagnosis of MS. But this gentleman is aged more than 50 years and has a number of vascular disorders, which means we want to be sure, we want to avoid the misdiagnosis. I showed you some of the lesions that look not really MS-related, but rather age-related. So for this gentleman, we have used actually the neurological examination, which remains important, and we decide to kill 2 birds with 1 stone. And instead of doing the CSF, considering that this gentleman presented with spinal cord symptoms involving the 2 legs, we acquired spinal cord images that showed spinal cord lesions, which means that we were able to demonstrate the involvement of 4 topographies. One of these topography is the spinal cord that is very typical of MS and less affected by comorbidities, so that we were able to do the diagnosis of MS. In a limited number of cases that here we have estimated below 10%, we saw in clinic people with only 1 region affected. I know it's a small number of patients, but possibly it's the most interesting patients that we might see in clinic. We have 2 different possibilities. The first possibility is people with progressive onset MS and at least 2 spinal cord lesions. The second possibility is patients with just 1 CNS topography. This is a 44-year-old woman who presented with progressive onset sensory symptoms and bladder dysfunction. Brain MRI was absolutely normal, but spinal cord MRI showed multiple spinal cord lesions that, to be honest, look very typical, posterior part of the cord. Ovoid shape. So in this case, with the current set of criteria, we are able to do the diagnosis if we demonstrate positive CSF, central vein sign, dissemination in time, but of course we cannot demonstrate 4 or 5 topographies, brain MRI, I told you it's normal. Please notice this is the only differentiation that the current set of the new criteria do between progressive onset, relapsing onset MS, but I'm sure that Wallace-Brownlee presentation afterwards will further elaborate on this decision. So in the past, using the past set of criteria, this lady would have not have MS anyway. With the new set of criteria, we gave a GAD injection and we demonstrated 1 GAD-enhancing lesion in the spinal cord. So this lady has MS. Alternatively, we could have had the CSF analysis. Here I have put in gray the CVS sign. We have very little evidence on the CVS sign on the spinal cord, and perhaps there will be room for getting more information in the future on this topic. Here we have, I think, what is the last case of my presentation. And we have a 22-year-old woman with acute onset of sensory symptoms in the right limbs and some pyramidal signs of an examination. And she also had a very nice response to steroids. Brain MRI, unfortunately, only showed periventricular lesions. Please notice that the lesion in the posterior part of the brain is not really periventricular on this slide, but is periventricular on other slides, but you'll understand later why this lesion is relevant for this case. So here we have only 1 region. Spinal cord, MRI, and OCT are normal, so we tried to demonstrate more the involvement of more than one region, which leaves us no other option than either doing the CSF and then seeing how things move from there, or waiting and see if we are able to get dissemination in time. I think we would have all done the CSF analysis to this lady already with the past set of criteria, and indeed we demonstrated the presence of kappa index and oligoclonal bands, but with the past criteria she would have not qualified for the diagnosis of MS. Actually, this lady came to clinic with SW images where we were able to demonstrate one paramagnetic rim lesion, which based on the new criteria, this is enough for the diagnosis of MS. So in this specific case, we have only one brain region, positive CSF, and the presence of at least one iron limb lesion. So in terms of practical implementation, based on our experience over the past month, the new criteria will be very likely to support us in many multiple ways. First of all, an earlier diagnosis. As you saw, based on the first MRI scan and also optic nerve imaging, we were able to do the diagnosis of MS, especially to individuals who were previously diagnosed with radiologically isolated syndrome or myelitis, so rather a description of the clinical picture rather than a diagnosis. Another possibility is the easier diagnosis, less CSF analysis, which I think for many can be a pro, and less gadolinium. This is also something environmentally friendly, using less gadolinium, so perhaps another push towards global applicability of the new criteria. And also less misdiagnosis. For the first time in this criteria, we have a set of tools that hold very high specificity for MS. Central vein sign, paramagnetic rim lesions that we can use as needed to make sure we are doing the right diagnosis. But I think what has really allowed is that we have been doing the diagnosis of MS within a biological framework, detecting disease mechanism, detecting disease-specific features more or less independently from the variety of clinical presentation or lack of clinical presentation and through the lifespan. I'll show you a case of 18 years old and a case of 62. So, of course, there is something to implement. My general advice is that brain MRI shall be acquired with SWI sequences or newer sequences that are much better at detecting central vein sign or paramagnetic rim lesions are due to come to clinical practice hopefully soon. And of course, there is the need to acquire images of the spinal cord and the possibility of having also information on the involvement of the optic nerve by using different modalities, including visual evoked potentials or CT or MRI. The CSF analysis remains important. And here we do not only the oligoclonal bands, but also we need to measure the kappa free light chain to do the K index, of course, in CSF and serum. So I think the point I've tried to make with this presentation is to try to avoid unnecessary complexity. The new criteria are much more flexible than the previous. You get someone in clinic, you assess what is the presentation, incidental, typical. Then you start from the first MRI, from the number of new regions on the MRI, and you do what is more reasonable, what is easier to do. I'm sure there are centers that are super good with the visual evoked potentials. Others would prefer the OCT, and that's perfectly fine. This is within the applicability of the criteria in different settings. And definitely not every person with MS will need to do everything, but every person will need to do what is easier to be done or what is needed to be done. Last but not least, let me thank all the participants of the McDonald Criteria Initiative who have contributed